Good evening, everybody, and welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Alain Epinette from Lille, France. Dr. Alain Epinette is an orthopedic surgeon working in the Department of Hip and Knee Reconstructive Surgery in northern France, close to Lille. Over the past 25 years, Dr. Epinette was involved in research on hydroxyapatite coatings in arthroplasty, highly cross-linked polyethylene matters, and hip mobile wearing outcomes, and has several publications and books on this subject. Dr. Epinette has also focused his work on computerized and outcome studies in orthopedics. He's the founder and CEO of the ARIA company, devoted to development of software suites and monitoring of clinical studies. Dr. Epinette has been the past president of the French Hip and Knee Arthroplasty Society and continues to be the webmaster of the society website. Dr. Epinette is currently the president of the European Hip Society, and he'll be the Congress president for the European Hip Society meeting to be held in Lille, France during September 10 to 11, 2021. So today it's my great honor to introduce you to Professor Alain Epinette from Lille, France. Over to you, Professor.
Okay, thank you very much. I don't know if I must say good morning or good evening, or but anyway, I'm delighted to, and I thank you very much for the invitation to speak about a so exciting topic. I mean, what benefits does technology bring in orthopedics? As previously said, and I thank you for your kind words of introduction, I am the current president of the European Hip Society, and I will be happy to invite each of you for the 14th Congress in Lille, France, September 10th and 11th. Okay, so what can we expect from such a title and such a topic? What benefits does technology bring? We can speak about better education. We can speak about prosthetic devices. We can speak about also what is very important, a better quality of life for our patients. So the first is better education for trainees. And everybody knows the training on cadaver, but cadaver studies are not so exciting today because it's expensive, it's sometimes inefficient, it's difficult to implement, and they can lead to sanitary risks. So the future is now in our hands right now with virtual reality. And the virtual reality is very, very, very exciting because we can feel the exact feeling of OR. And so we can think about a better education for trainees with virtual reality. And again, it's a future because it's surgical simulation that enables unlimited simulated theaters hours, any site of surgery all over the world, and reduction of operating errors. It can guide you step by step to excellence, and it's simply off the shelf with laptop and headset. So it's not a very expensive technology, and it can afford you a real education about. So we can think about virtual reality for training, for surgeries, but also to learn new techniques or new approaches in our daily surgery practice. If I can explain something about that, it's not only you are the surgeon, operator, but you can be assisted by other persons in other parts of the world through this virtual reality. And here is just an example.
Now you'll see me in virtual space. You can see, here's my head, and I have hands, fully functional hands. I can use all my appendages. You see that? I can also use them to grab these tools over here, like this pin driver, and pull triggers. This okay. And make that first cut, removing the anterior or the distal ends of the femoral condyle. Okay.
The eyeball will now adjust trajectory.
And lastly, the tibia. Now, to impact it into its final position on the distal side of the femur. And lastly, I'll put the poly inlay component between these two. Okay, concludes our demo for now.
Okay, that's very, very important to know that it's the exact feeling. The first time I got the opportunity to try it, after 10 minutes, I had the feeling I was in a real operative room. That's certainly very important for education, for trainees, as general skills, but also for getting comfortable with new devices and new procedures. Now, the second topic is about prosthetic devices and what can we expect from technology for prosthetic devices. And well, I have to speak about the additive manufacturing, 3D printing in orthopedics. In fact, 3D printing is very well known now everywhere in the world. And it's a real industrial revolution. And so it's very important to know that we can have some good topic to explain about this 3D printing. First is what exactly, what does mean 3D printing? How is it done? What are the applications in orthopedics? And finally, what is the perspective and the future of this in our surgery? The first is to say that we are used, speaking about subtractive manufacturing for all we have known till now. But now the powder technology is really additive manufacturing. And so if we consider two families of processes, making it possible to manufacture near net shape parts, we can speak about the manufacturing on a powder bed or by material deposition, and the first powder bed system is the more commonly used. And so the first application for additive manufacturing was the PSI cutting guides, the personal guides for total knees. And so we have had some good experience with that. And so this allows for getting personalized instruments. The second is the need for some new instruments, prototypes or instruments. Here in this photo, we are just in a boat, and so in a boat, it's very important to have some new devices immediately on the shelves. And so we can have the manufacturing of retractors or any other instrument that can reduce the cost by 1/10 about the final price and immediately getting on the table. So right now, we also speak about prototypes, and every kind of prototype can be manufactured simply by computer technology. And this computer technology allows you to get immediate prototypes. It's cheaper and it's faster to get. But the most important application in orthopedics is certainly the porous surfaces for bony ingrowth. And so it's not a metallic apposition, it's really in bed manufacturing. And so we can consider that the bony ingrowth will be very important in such a surface. We can speak really about bony ingrowth and not only bony on growth as in the past. The final step for this additive manufacturing should be the custom complex implants, especially in oncology or in case of very severe bony defect. And we can, by by means of this additive manufacturing, get exactly the anatomy of the defect and so having the possibility to restore them at best. So finally, these prosthetic devices afforded by 3D printing are exciting technology. We must speak about anyway some regulatory constraints, but in the close future, it will be very common to use this technology that is already used for cups or for tibial plateaus in total knee arthroplasty. The question of production costs remains fundamental because we need to have a perfect implants to fit in the body. Anyway, we have to speak about the final point that is not the least one, but last but not least, we must speak about the better quality of life for our patients. And so the most important question is why robots can be used for our patients. In other words, these patients, are they getting benefits from our computerized surgeries? In fact, we have now robotic procedures that are commonly available under two basic types. The first is shared control. The surgeon performs the surgery and the robot uses the pre-programmed information to provide steady hand manipulations of the instruments. In this category, in this family, we have two types. First, the simpler is a Navio, and it's like a gun, and so you manipulate the gun and under the pre-planning obtained by computerized means. The second is the most efficient. It's a Mako from Stryker or Rosa from Zimmer, and these two systems are the most common used in orthopedics today. A third possibility is a supervisory controlled. It's a T-Solution 1, and the robot executes a series of pre-programmed actions and actually performs the surgery instead of the surgeon. At the end of this lecture, maybe we will have some questions, and I will be happy to speak about these two systems in more details. This is just an example of the Mako, and so you will see that in the OR, it's a huge system, but it helps to perform the surgery as we do usually, but we have a direct control on the screen at each step of the surgery. We can take into account the pre-planning with the imaging systems to create a pre-planning reproducing exactly the reality. The Navio is different because you must guide. It's not a saw, it's just a burr. And so the burr prevents you from any problem of going too far or too deep. And so you can, in such a way, locate exactly your implants at the right position given the pre-op planning. The Navio is the second system. And just some words about the active robot technology. This is just a system where the surgeon has nothing to do. And it's just a system that is guided by the pre-op planning and with the trackers that are on the two parts of the bones. And so the robots really perform the surgery instead of the surgeon. That it's another way of doing, and maybe it's a very promising technology. Being said that we can discuss about what happens if the robot is failing here or there. So anyway, these systems are very important now in our surgeries. And the real question we had at the beginning of this lecture on this topic is just to say, do robotic surgeries prove a significant better quality of life versus conventional implantation? The problem is that very often when we hear about the surgeons who are promoting this surgery, it's about 6 points. The robot follows the patient-specific plans and allows for precise control of positioning. But we should say that navigation is doing the same. And so we have to discuss again about the real benefit for the robots. The surgeons who are speaking about robots speak often about superior outcome and faster surgery that has not been so far proven on a significant manner. And finally, when you compare the shorter hospital stay and less soft tissue trauma, all these speakers are speaking about the robots as compared to regular procedures. But now with the rapid recovery procedures, the hospital stay is shorter, and also the MIS procedures are helping for less soft tissue trauma. So when we look at the benefits in the long run, I mean after 10 years, we have two lectures, two published papers that finally concluded that the computer-assisted surgery used for TKA allow for a better restoration of a neutral mechanical axis, but there is no any substantial advantage in survivorship, function, or quality of life at 10 years after TKA. The second paper, meta-analysis, also concluded that they observed better postoperative prosthetic alignment results in the TKAS group, but no real significant difference in long-term functional outcomes and prosthetic loosening rates between the two techniques, I mean robotics versus conventional. So the problem again is to speak about the future, and the final question should be, will we be soon operated on by robots? I'm afraid to say now that it's not time right now to envision such a future, and so suddenly we have a long way to go, and our the surgical hands will be very important in the future. Anyway, we can speak about a better quality of life that can be expected, but not yet been proved. The question of cost remains fundamental, because all this technology has a cost, and it's a real cost for clinics and hospitals. And so we must take into account these costs versus the conventional procedures. And the final question is the IT technology dependence. Finally, in case of problem, who operates? Who operates? Is it the surgeon? Is it the engineer? The question can be very important to ask in the close future now, when speaking about robotics. Well, my take-home messages about these benefits and technology, we certainly can state about a better education means the virtual reality offers significant help in educating trainees, but also for learning about new surgical procedure. It's cost saving, it's very easy to do, and it's a fantastic tool to get trained here and there. The second was about prosthetic devices, and again, it's an exciting and promising technology, But we used that for prototypes, instruments, but almost all on surface rawness for cups and tibial plateau. About the quality of life afforded by robotic surgeries, we must take care about the cost. We must take care about the need for proving the benefits. But anyway, you know that the more often we are speaking about personalized surgery, especially for knee replacement, and in such a way, the robots are better than the human hands. So these are my take-home messages, but the last message should be about the next EHS Congress in Lille, and all of them are invited. This Congress will be held both presential and virtual, and so from any part of the world you can participate, and we invite you, and we will be happy for you to attend this Congress. And all the details can be found on www.ehs2021.org. Thank you very much for listening. Okay.
Thank you very much, Professor, for that wonderful talk on recent advances in technology. And a couple of questions, Professor. First one is with respect to virtual reality. Now, do you think there is an explosion of virtual reality companies, especially because of the pandemic? One of the reasons is a lot of fellowship programs are finding it difficult to train their trainees. So do you think virtual reality was increasing during the pandemic?
I don't know if this virtual reality is increasing, because I've been working with them. I have no conflict of interest, but I was very interested in this new technology. And so we can say that the movie I presented, for example, is coming from a company who has 4 centers in the world. So it's not so often used so far. But again, they are doing progress all the time. And in Europe, I guess we have 4 or 5 centers. But now all the companies, the big companies, are pushing in this, pushing the limits. And especially, just an example, in France, we have a system of teaching residents, and we are launching a system, a global system on a national area within the frame of Epinette French Society. So so far it's not so well known or well used, but I think that in the coming 5 years it will be the rule.
Thank you very much, Professor. And the other thing is 3D printing. There is so much of advances happening in 3D printing. What is your personal experience with using 3D printing in hip arthroplasty? Do you use in revision hips where you are locating the acetabular defects?
In fact, it's very interesting to use this technology for a very important defect, Paprosky 2, 3, or 3. Because in this kind of revision, it's very important to mimic exactly the normal anatomy of bone. And in such a way, it's very important. But it's a cost technology. The costs are important. You must have imagery with IRM, MRI. You must reconstruct with phantoms. And so afterwards, it's time consuming too. So in revision hips, or knees, I think it's very important for the most important defects. But on a regular basis for surgery, we use all the time with the cups. And some major companies now use this technology for getting a very good ultra-porous system of bony growth, and especially for cups and for tibial plateau, not for stems, because it's very fragile, and so the technology is not acute enough to allow for that. The same for the femur. because the surface for bearing surfaces are not so far compatible with this additive manufacturing. And so again, for cups or for tibial plateau, it's very important. And I've spent 40 years, 30 years for hydroxyapatite. And unfortunately, I think that the hydroxyapatite is not indicated for this ultra-porous system obtained by 3D printing.
And what about trabecular metal? Are you able to use trabecular metal using 3D printing?
Trabecular metal, it's the same. If you have trabecular metal, the original was not 3D printing. It's just a deposition. But what we have used for that is just for wedges, for example, in case of defects. And there is a huge competition between allografts and these devices obtained by ultra-porous means. And so I think that it's always a true question. And in my mind, I think that this trabecular metal, from any company, will make the allograft out of interest in the close future.
Thank you very much, Professor. And just one last question before you wind up. What is your experience with regarding to robotic surgery? Do you think the patient requires a CT scan or an MRI before that? And does that increase the radiation risk to the patient?
That is a very important thing to know about. We have the imageless and we have the MRI before. If it's imageless, so we have no radiation, so obviously. But in my mind, it's very important to speak about this robotics. If I can say some words about unicompartmental, I have been taught by Philippe Cartier 40 years ago to implant the uni knees with a fork and a knife, and with the Cartier system, and you know that it's very antique. But after 40 years, and my main activity, the surgical activity, was the unicompartmental. And I think that we need some feeling about that. You need a nose, you need the eye and fingers. And when the first time I heard about the robotics in uni knees, I met the engineer who was working on this, and I said, you will not succeed with robotics, because the uni knee is a system that needs just a very good feeling, and you cannot reproduce it. And finally, I was very surprised, because I said you must add artificial intelligence module in, and they have done. And so now I have the experience of the robotic in a friend of mine in Nîmes, and with the macro, and it was a uni knee. And so I was surprised, because when looking at the surgery, I say, this robot is exactly what I'm doing. And so I think that for somebody who has a very good experience and a very strong experience, does not make any difference. But for the new surgeons, for the Chinese, for the new surgeons who are not experienced with the uni knees, it's a fantastic tool. Believe me, it's fantastic, because just to finish on this subject of the uni knees, I've been the director of symposium about the failures in uni knees. And we saw that it was a huge difference between the experienced surgeon and the not so much experienced surgeon. And they had a lot of failures. And thanks to the robot, I think I can expect that these not so experienced surgeons will have good results, as good as the best surgeons. And so this is a fantastic hope for this robotics.
Thank you very much, Professor. Professor, can you stop sharing your screen if you don't mind?
Yeah, sure. Okay, up.
Okay.
Sorry for that. I am just looking to go back. Okay. Arrêtez, stop. Okay, sorry, up. Let's go.
Okay, yeah. Thank you very much, Professor. And thank you for the fantastic lecture. And I'm sure this lecture is going to benefit a lot of people all over the world. And best wishes for a fantastic European Hip Society meeting to be held in Lille, France in next month. Thank you so much, Professor.
Thank you so much. Thank you. Bye-bye, and stay safe, everybody.